So the term LMICs, as many of you must be aware about, is a term that actually comes from the World Bank data that it's based on GDP. So in this map, to summarize it, everything that it's not like a dark green colored country is considered a low and middle income country. So overall, the total population living in LMICs comes around 3.4 billion people. So as I was, making this talk, I was in clinic, so I had something that made me realize that made me come to a very important realization. So I had two very similar patients. On one hand, I have this 39-year-old woman married. She has one kid. She's a college professor. She owns 2 cars. She has a chauffeur. She has a very nice private insurance. And afterwards, I saw this other patient. She was a 41-year-old woman, single with 4 kids. She is currently part of a cleaning staff in a private home, and she moves around usually walking or by bus. And she actually got her treatment based on donations by different, NGOs and very kind people that share some of their wealth with her, so she could go and get actually the best treatment available that there's currently for triple negative breast cancer, both, as you can see, have like a locally advanced disease. Nonetheless, even though both patients were diagnosed with similar diseases at similar stages and received very similar treatment, I came across some important things. So I invite the audience to give some of their thoughts to the following questions, like who of these two patients is more likely to develop lymphedema or chronic pain, who is more likely to develop a cardiovascular morbidity and also metabolic disorders, who is more likely to have developed infertility, and also who is more likely to develop some type of neurological challenges during her long-term survivorship, such as, anxiety and PTSD. And the answer at the end of the day, even though this disease was very similar and the treatment was very similar, is going to be patient 2. And the actual, one of the main motives I've come to that realization is, for example, when you go and see a high-income country, like the classic example, the United States of America, you can see an important proportion of disparities, of socioeconomic disparities. And for example, in the United States, that overall as a country is a high-income country, as you just saw it in the map, 13% of the population live below the poverty line. So even though in similar contexts, every patient's journey can greatly vary due to socioeconomic factors that are not related to diseases. And why do we have even disparities in cancer care? So actually, it's a very complex problem that could not be addressed only on one end. You have some cultural factors, behavioral factors, environmental, general health. So it's a quite complex problem to tackle. And even more, this problem might be accentuated in the survivorship phase. So usually most of the countries' cancer budget goes either to early detections and mammographies and whatsoever, colonoscopies, and most of the budget actually goes into treatment, because that's our reality. That's how the medical system is currently more based on. Nonetheless, the lesser amount of budget and resources go into survivorship research, survivorship care, advocacy, and clinical practice. So this problem that exists with the budgetary and the disparities in the economic framework is probably even more so during the survivorship phase. So actually, circling back to the title of the presentation, it's more of the challenge of long-term cancer survivors, not limited to LMICs, but overall in resource-limited settings. So some basic concepts of survivorship. Cancer survivor is considered the patient that was diagnosed with cancer from time of diagnosis until the end of life, even though the cause of the end of life might not be related to cancer. This is like the classic description. So around the mid-1980s, Dr. Fitzhugh-Millan was the one that actually made the distinction between 3 important patients. So actually long-term cancer survivors that we have like a time point of 5 years, a very arbitrary time point. If you come and ask me why 5 and not 7 and not 3, that's something that somebody came up and decided that's going to be. But overall, it's a very different phase. And my point in this is that it differs from the other phases, because the acute phase usually is the time around the diagnosis, that people are worried about treatment, surgery, radiotherapy. And right now, going to the long-term survivorship, people are going back into their new normalcy. So that's why it's even more challenging, because most of the resources have been already used during previous phases of survivorship. So when we look, and actually echoing a little about the introduction that was very kindly given to us, the number of cancer survivals is going to increase. That's a reality. That's a reality in the States. As you can see, for example, the number of people that are currently alive since the 5 years from diagnosis, 10 and 20 years, which account about 5.4 of the total population in the US. But really, what are the chances of a woman diagnosed with breast cancer to have a 5+ year survival in different countries? So some data, for example, in India and in Nigeria, come to the percentage of around 60 and 40%. So even though this percentage is numerically lower than the United States, overall cancer mortality rates are predicted to decline. So it's long-term cancer survivors are something that every clinician, every oncologist, even every PCP is going to come across. That's why I want to sensitize everyone about this coming challenge. And overall, it's a very complex system, because you have to deal with financial toxicity, long-term complication, mental health management, quality of life, late toxicities, sorry about that, and also do some health monitoring, not only due to the cancer diagnosis, and finally state a survivorship plan in the best case scenario. What's the problem? So in the Middle East, they did a couple of interviews that actually I think it's going to help me be a little more clear about the problem we're having as low and middle income or regions with scarcity of some resources. We have problems that, first of all, some insurances don't cover all clinics. So it might cover the oncology clinic, but not the, for example, endocrinology, not for example, the cardiology or the fertility treatment. So that's one problem. Also, the follow-up times in many countries are not as ideal as they're supposed to be. For example, time interval between visits can differ for standard of care from about 6 months to 1 year and even more. Also, at this phase, probably as people cannot return to normalcy, communication and interplay between other patients might be less available. For example, at the time of treatment and diagnosis, it is very common that they have this, these advocacy groups and even this connection between patients, that they see each other during the chemotherapy or during the radiation therapy. But in the longer term, they might lose contact with some of their peers. So that's also another important burden our patients face. And also, the economic situation that is not dependent on them. Overall, like the economic situation on the region of the country might also play an important burden on the patients. And finally, the number of clinics available that are not centralized in many countries, including mine, are a problem for patients. It is not the same to, be a housewife that has the opportunity to have a car and move around than to be somebody that has to take 3, 4, 5 buses to their follow-up visits. And even though if the clinics are not like cohesive, they might have to go to 6 different clinics on 6 different days. And that might mean that they have to take in a short amount of time, a total of, 30+ buses. So definitely there are some areas that definitely patients that stem from resource-limited setting do suffer more. And overall, the cancer care continuum, shows a lot of disparities, for example, in the screening rates, the time to diagnosis, the lack of research and coordinated efforts, the lack of access to novel medication, and a lower rate of adequate timing and surgery. So I want to take a second just to be more clear on the last point. And why is it important? So when you don't have for timely access, let's stay in the line of breast cancer, when you don't have timely access to radiation therapy. What do the guidelines say? What do we do as physicians? So if a patient cannot access to radiation therapy, well, they should receive a mastectomy, just to say a very brief example. And it is proven that patients who undergo a mastectomy are going to need more frequently rehabilitation services. Another example is, for example, in male patients with testicular cancer that are, stage 1 seminomas, that might undergo only surveillance. But if my patient has to travel 3 or 4 buses to get a CT scan every 3 or 4 months, it is much more feasible for them to get chemotherapy, so they avoid many times these very complicated follow-up schedules. So at the end of the day, treatment does impact on the quality of life in the late survivorship phase. And a very astonishing number is that there is also a systematic problem in the healthcare. So they did this study between African-American patients and non-Hispanic whites, that overall about 20% less patients that come from African-American ancestry were informed the need for follow-up care after finishing their treatment. So that's a very astonishing number that really reflects the complexity also that comes and the problems that come from the healthcare providers such as myself. So overall, this all joins into particular barriers for survivorship. We're not talking only about the already complex survivorship cancer care continuum, but also we have to take into account these specific details. And is there really an impact on long-term follow-up? You might think, well, if they have less access to treatment and they have less access to surgery and whatsoever, so they might not have an impact in the 10-year survivorship rates. And that's actually true for us. So when we make an estimation by social deprivation quartiles, specifically in childhood cancer, as we can see here, patients that stem from socially deprived areas have a significantly higher hazard of death, as we can see when comparing, for example, patients that do not stem from very deprived backgrounds in the Q1 when comparing to patients from the Q4. So this has an overall impact in the long term, even in probably in the most significant measurement that we have, which is survival. And how do these barriers actually look? What happens to our patients? So we know that they have lesser survivals, but they might also look as no-shows or appointment cancellations. For example, around 70% of patients that come from the adult and young non-Hispanic Blacks are lost to follow-up in some clinics in the United States. Also, a higher rate of long-term comorbidities, as a higher rate of cardiovascular diseases and endocrinopathies, especially in people from African-American and Hispanic ancestry. Overall, they have worse outcomes, as I showed you in my clinical case, as they have double the rate of lymphedema, a considerably higher amount of distress, anxiety, and depression, and as I mentioned, a higher mortality. What is known in some resource-limited settings? So, of course, I'm going to be biased and Mexican, so I'm going to talk about Latin America. So most of the research conducted in Latin America, this is a very, very nice paper done by a brilliant colleague from Peru. So most research comes either from Brazil, about 70%, and Mexico, around 15%. And most of the research in the long-term survivorship is related either to surveillance of management of psychological effects and management of physical effects. So when looking at the overall quality of the publications, there's still a gap on the development of, for example, on guidelines and things that you can actually apply to your own context. And when we look at the types of malignancies that are present in these papers, for example, comparing to the rest of the world, we have a problem that our epidemiology, at least what's reflected in these patients, does not look like the epidemiology in the rest, at least in the United States of America, where the 3 most commonly associated malignancies with long-term survivorship are breast, colorectal, and prostate. And here we have more of a problem with cervical cancer, leukemia, and thyroid cancer. And are patients even willing to take part of a survivorship plan? Definitely yes. When surveyed, of up to 97% of patients are interested in joining a survivorship program if invited. And when you look actually at the NCC guidelines, you can see that, for example, this is a very nice one because they give you example of physical activity and they do all these nice things like pickleball and vinyasa yoga and tai chi. But at the end of the day, they're based on American cultural and lifestyle. So this might be a problem when we're trying to extrapolate evidence to some of our particular patients. So what are some solutions that might help aid these long-term outcomes in underserved populations? Some things like bilingual services, caregiver engagement, and cultural preferences have shown to be positive in the engagement of patients in long-term survivorship plan. And also, I think it's important to adapt to oneself's own setting. For example, instead of what I do, instead of, for example, recommending pickleball to a patient, I would say rather go play soccer or do a Zumba lesson because of the culture we have here in Mexico. And instead of vinyasa yoga, I would recommend them going around the block with your neighbor, some kind of things that we know that are actually realistic to our setting. Also, it is important development of language for non-English speakers. So there's still a gap. Of course, there are some guidelines made in Spanish. Spanish at the end of the day is the fourth most spoken language in the world, but still there's a gap in native tongues. For example, we don't have any, or we have a very limited amount of tools in Tarahumara and Guave and Nahuatl that are some of Mexico's native tongues. So there's still an important area of interest, and we should seek to training community leaders, introduction of navigation programs, and trust in the communities through the engagement of cultural humility. So cultural humility is the ongoing process of self-exploration with a willingness to learn from others. So I'm going to go into much detail here, but this is one of the methods that has proven to be better in the development of trust between communities, and one as a healthcare provider should be practicing with our patient population, and also the creation of registries. So there's some individual efforts, at least in, as you can see, in Mexico and Brazil, some survivorship care plans in Africa and Colombia. Nonetheless, they are individual efforts. So in the future, we're hoping to make these efforts more of a national perspective, more of a national thing, rather than some individual data for single center registry or two center registries. And this is a very nice example of what they're doing in Brazil. So they have these semi-structured script interviews, so that allow the patients to start answering before their consultation. And I think it's very important also to try to look for the development of resource stratified guidelines. As I mentioned, most of the research done in Latin America are limited to what's shown in your screen, mainly related to surveillance and management of physical and psychological effects, but no specific guidelines, and only one SP was developed in Latin America. So what I think would be like the ideal future is we start developing according to income setting. For this is just a very brief example on how to give a follow-up regarding the clinical assessment of cardiovascular disease in the low setting, and for example in the middle income setting. As you can see, it needs more resources because more resources are available. So I think that might be also a way to address these problems. And at the end of the day, we're looking at changing policies. So for example, there's already some strategic lines in the 10-year plan for cancer control in Colombia that they're looking for improvement in quality of life of cancer patients and also survivors. I'm going to close my thought with the following needs I think are needed to develop in the future, and also like a scope to what I consider would be ideal. So as a healthcare professional, you need to practice empathy and cultural humility with all patients, so you can actually adapt what's already available as evidence. and make it more personalized for your patients. We also should seek for increasing research center in minority and long-term survivals, build community-based survivorship programs, start registries to better understand our patient current situation and needs, and finally to create some resource stratified guidelines according to the social, cultural backgrounds and the resources available in that particular setting. And with that, I finish my thought. And once again, I want to thank the JCMT for this kind invitation.